Okay, let me just share my screen. Okay, can everyone see the initial slide?
We can.
Yes.
Or I
Okay,
can.
great. And I just introduced some supplemental information. I had provided this several weeks ago to the Health Operations Council, but I was able to get additional drill down information. As I had mentioned, I'm also in the midst of doing some analysis by zip code, but so it'll be on the veteran population, some patient growth results, as well as implications for further outreach. And so what I have is a 2022 analysis. I also go back 5 years. And we'll look at the veteran population as well as enrollment. Enrollees don't necessarily present for care in person, but they are potential veterans. So we'll look at those numbers. We'll look at market penetration by the markets as well as counties. And we'll look at the unique veterans treated. I was able to break it down by gender. We'll look at total women veterans within the VISN 2 market. I was also able to drill down to patients treated by race and ethnicity. We hadn't seen it in this level of granularity before. And so we'll look at the percent of our total veteran population that we are treating. And then we'll discuss some further implications, and I think it'll be a good discussion point here. These are the unique veteran growth numbers through April, and VISN 2, you can see, is down 2.9%. Earlier part of the year, we were actually positive, but it started to reduce. But you could see we treated 240,000 unique veterans, and you can see where we are as compared to the other VISNs. VISN 1, I know we've used them often as a paragon of outreach, but they've actually slipped in their patient growth as well, the Boston VISN. And if we look at it by our individual facilities, you can see Bronx, Western New York, and we have a wide variation. New Jersey, Syracuse, and Finger Lakes had improved. You can see where Albany is at minus 1.6%. You had been positive over several years, and we'll look at that going back to 2016. The VISN is down about 6.7%. We were at one point, if you go back further, we were over 300,000, 293,000 in FY16. 274 was last year, and we should hit about 265 with the current rate of reduction for 2022. But you look at it by facility, and I've actually gone back even to 2000 for some of my other presentations. You can see various time frames that we've done. I've limited the slides here just to a few historical ones, but you can see at Albany, and I ranked it by all 138 VISNs facilities nationally. You can see Albany's about at the 18th percentile, down about 5% in that 5-year period. This is the veteran population. We actually have 878,000 veterans estimated right now. These numbers will be more precise when the census data comes out shortly. We will have that, and we'll update some of those numbers. These are based on actuarial projections. We were over 1 million in the 76 counties in the catchment area. So you can see the eligible veterans. Those are based on eligibility based on income. So 651,000 eligible, and the actual veterans that we treated, 274,000. So that's a much smaller number. We do have the potential to see more veterans, and we have the capability and the capacity within our clinics as well. You look at the enrollment-based market penetration, that's just enrollees, not necessarily veterans that we saw. We're at 61.3%. You could see Dallas Vision 17 is at 70 point. So we are on the lower side nationally. If we look at it by market, you can see our visits, and I basically interspersed them based on where we are. You can see Puerto Rico, Minnesota, South Dakota as 1, 2, and 3. And then I showed in descending order, Finger Lakes, 67.8%. The eastern part of the state, encompassing Albany, 62.6%. So we do have quite a variation. And this is just based on enrollees, not necessarily users. The unique veterans treated is a different matter, and the former is, and if I can go back, this is what VA uses officially, and it's based on enrollees for all of their planning models. This is actually something I developed. We took it for granted. A lot of people said, "Don't we use unique veterans treated?" Well, we don't. That's not the official number, but we've made a decision within Vision 2 for some years that we would use that as our numerator. We also look at the enrollees, but we feel that based on the VERA model and other important indicators, uniques is a much more accurate numerator for market penetration. But you could see us at 36.8%, much lower percentage that we've actually seen versus those that are eligible based on means test. And then veteran population and eligible veterans by market, you could see it varies fairly widely. The eastern part of the state, 40.1% of the eligible veterans. But on the right, you can see we have 377,000 eligible veterans based on means test that have not been seen. We actually have about 600,000 of total veterans not seen, but we're not using that because it would not be a practical number, since many of them may be more affluent, have their own health insurance. The 377 is a much more realistic figure. In addition to what we're seeing now, those are not presenting for care. And these are the veteran population patient treated numbers. You can see the end of year veterans for eastern part of the state, 95,000. The eligible veterans are 71,000, but the unique veterans treated for last year at Albany, 21,000. That should be, I'm sorry, 28,000, and that should come down slightly, probably another 1,000. These are some maps that I created, enrollment-based market penetration, where you could see 70% or more is in the dark blue, in the light beige, 49% or below. And I magnified it so you could see it more clearly by county name. So I've got the upstate region that's magnified, and you could see across the state, the western part, Buffalo, Finger Lakes, higher penetration. As we go east, those counties encompassing the Albany region, you could see a lower market penetration for enrollees, and that's also true of uniques. Uniques, again, would be more difficult to do because I would have to create them manually. The VA does not have official market penetration using users, so I would have to create that myself. I can do it given some time. Most of what I do is actually in the patient care area and veteran outcomes. I'm doing this, trying to try to help out, but it is a very time-consuming process if you were to focus on that outreach.
Joe and Sean, can I ask a quick question about that slide?
Sure.
The one you set up. So if I'm understanding, darker blue is better, correct?
Yes, it's a much higher percentage of the enrollees out of the total numbers that actually are potential users, and that's, yes, we do want a higher percentage that sign up for care. And as you can see, the western part of the state is over 70% in many cases. It's variable from 49% to some of the counties, as you can see, the Albany area from 57 to 63, but not much higher. It's usually much closer to 50.
Well, and the only one I see that's really is Hamilton, which I know is a very small county numbers wise.
Right, exactly. And when we look at the actual numbers, it'll be much clearer. Market penetration doesn't account for, as you say, how heavily concentrated that is based on population centers. So it is good to look at the firm numbers, not just the percentages, and we have those as well. And this is the downstate area, and similar to the eastern part of the state, it's actually lower. The market penetration would be, with the exception of Orange County, near the Westchester area, it's on the lower side as well. And if we look nationally at maps that I've created, we tend to be on the lower side as we looked at some of those national comparisons a few slides earlier. These are eligible veterans not seen, and so I wanted to create a visual depiction of the 377,000 veterans that we have not seen that are eligible based on means test. And how do we look by market? And you can see the eastern part of the state, about 43,000 veterans that could potentially use us. Now, we're not being unrealistic. We recognize we're not going to see even a substantial portion, but with 275,000 veterans or so that we're treating, I've mentioned to Dr. McInerney that, even if we increase to 290 or 300,000, we don't have to cut into that huge portion of 377, which would be unrealistic. We do have the capacity in our clinics to perhaps treat another 20 to 30,000 on a VISN level, and you can see each of the markets. So just imagine for Albany, going from about 27 to perhaps 30,000, it looks like there is capacity to do that, and we would generate an economy of scale that way. One of the things we found is that VISN 2 was actually the second largest VISN in unique patients 20 years ago. We're now the fourth smallest. I have had these in some of the other slides. I limited it here again because I just wanted to finish up so you could have a discussion, but we have diminished in our size, but we were one of the largest, and our facilities, many of the individual facilities were among the largest of the 140 nationally. If we look at veterans treated by gender, we treated 20,267 as of last year. Should be up slightly in FY22, but we have 57,000 eligible women veterans, or about 35.5% are the eligible women veterans that we're actually seeing. And you can see the numbers by market. The eastern part of the state, we're seeing about 33.9%, or a third, but 4,152 eligible women veterans are not being seen. There are actually much more than that in the Albany area in a higher income level that would not be considered eligible women veterans. So this is a realistic number. And while we won't be able to attract all of those, you could see that there is potential for some upside growth for women veterans, which is very much necessary. So that's something that we'll be continuing to look at. And I created some new maps that I was unable to provide the last time presented to Health Operations Council. And let's see if I can believe I added them here. Okay, these are unique veterans by county. And then I did a magnification so you could see across the upstate area, which of the counties have the greatest numbers of veterans. Unlike the market penetration, these are actual numbers. The 1,599 or less in that lighter, the lighter shade that you can see on the right-hand side, especially up towards the North Country. And then in dark blue, 15,000 or more. Buffalo, Onondaga would be in that 7,000 to 14,999 area. But you can see Albany doesn't have very heavily populated counties that were with the large numbers for Vision 2, and you can see downstate the various counties that do have some of the larger numbers, as you would imagine: Nassau, Suffolk County, and New Jersey, Bronx, Queens, Kings. And these are unique women veterans by county. I was able to create these maps, and you can see once again with a blow up, you can see Albany would have between about 330 to 599, Rensselaer between 160 to 329, Saratoga the same range, but you can see smaller numbers as we go further up into the North Country.
Joe, can I ask you a question about the last couple slides?
Sure.
When you say unique, is it all unique, or all veterans, or just veterans? When you talk about that percentage that's not connected with the VA, or is it all veterans?
Oh, would be you mean that have not used us?
Yes.
Oh, that would be eligible.
Okay, gotcha.
Not total, so it's actually a more realistic number.
Perfect.
The other number is much higher.
Yep.
That they would be residing in the area, but they're not considered to be eligible veterans. You know, not that we're turning anybody away, but the VA does classify the veterans as eligible based on the income levels.
Perfect. Thank you.
And so you can see the eastern part of the state, as with the total veterans. You can see the women veterans, and similarly downstate. Of course, the numbers are larger in absolute terms, but also we could increase these numbers substantially in the southern part of Vision 2. I was able to break down the numbers by race and ethnicity through the first half of FY22, and you can see among the 270,000 veterans, 160,000 white, 37,800 Black or African American, 16,700 Hispanic. There are a number of unknowns that where the veteran does not identify their race or ethnicity, but you can see Asian, just over 2,300, multiple race and ethnicities are listed, 1,821, and then you have Native Hawaiian, 1,199, and American Indian, 980. I tried to get the total numbers that we have potentially, so we'll see that shortly. And these are the percentage of unique veterans that we treat, and you can see 68.8% are white, Black or African American 16.22%, Hispanic 7.2%, American Indian is about 1/3 of 1% of our total, Asian about 1% of our total veterans that we treat. And these are the percent of the total veterans treated by race and ethnicity. I don't think that this was ever shown before. I was searching a lot of non-VA sources for much of this information based on census information. So it gives us a good idea when we look at unique veterans treated in the first half. The total veterans, for example, for Hispanic veterans, 16,755. The total veterans in New York, New Jersey, 108,000. so about 15.5%. It's estimated we did not see 91,322. Similarly, with Black veterans, there is a much higher market penetration, much more willing to see the VA. And I did do a lot of analysis of obstacles by race, by ethnicity, who was more apt to present to VA. And you can see we are seeing 28% of the total African American veterans, but a good portion, still 92,000, that we have not seen in FY22 across our VISN. You can see Asian, 10.6% of the total. We are seeing just over 2,000, but there are 19,000 plus in the Asian veterans in the New York, New Jersey area, and American Indian, just under 5,000 veterans. We're seeing just under 1,000, or 16%. So it's probably the first time we're looking at it like that. But this kind of information is available, so we're going to be looking at it with greater eagerness, and with potential drill downs that I'm going to try to get by zip code and other ways of obtaining the information. One of the things I presented to the Health Operations Council is when we do outreach, we really should do it from the standpoint of meeting healthcare needs. There are race-specific risk factors for suicide, diabetes, hypertension, cancer. And this is an example of past year suicide thoughts and recent attempts. And you can see the percentages across our VISN. Serious thoughts of suicide, 5.6% for American Indian and Alaska Native. Suicide attempts are lower there, but African American, 3.4%. Serious thoughts, just about 0.3% for attempts. White veterans, 5.3% for serious thoughts of suicide. These are substantial numbers, and you can see the actual attempts. So these are examples. I have more research that I've done on risk factors for diabetes and hypertension and cancer. So when we do market, it is an important thing to keep in mind. There's a lot of literature out there, and so we can market our services based on actual need. Also important to consider who has health coverage based on some of the most recent numbers. You can see African Americans, about 79% have coverage, Native Hawaiian or Pacific Islander, 80%, Asian Americans, 82%, white Americans, 88%, but Hispanics, 68%, American Indian, 68%. So that's something to keep in mind as well. And just finishing up, I just wanted to reiterate things that we've talked about in some of these past outreach meetings. VISN 2 has certain factors that bode well for successful outreach. We do have among the highest levels of staffing and resources per patients treated. We are ranked 17th in FTE per unit of productivity, whether it be unique patients or VERA prorated persons. Based on some of the clinic capacity reports, we do have excess clinic capacity, many slots that are not being used. We are currently ranked 17th out of 18 VISNs, so we do have thousands of slots available in our clinics to accommodate veterans. We also have excellent access to care. We're in the top 25th percentile, but that access goes to waste if we are not seeing new veterans. And a lot of that is based on the access for seeing new veterans within 28 days. So we do have that capacity, and it's being unrealized fully. We also have high SHEP primary care provider ratings. We're in the top 25th percentile. So that bodes well for us. We have been able to provide high levels of satisfaction for veterans. Higher in primary care, we'd like to improve that in specialty care, but nonetheless, it is something that's enviable by others. And we do have the highest percentage of eligible veterans that are not being seen among all visits, 63%. And so we are ranked 18th there. If we put all of this together, there is potential that we could see tens of thousands of additional veterans that are currently not being seen. This is the FTE per thousand prorated persons that I spoke about, and while it varies across our facilities, all of our facilities are on the higher side. You can see we're about 25% higher and about 50% higher than some VISNs like Dallas and Denver and Atlanta, the three VISNs on the left. These are the SHEP provider ratings by race and ethnicity, and you can see VISN 2 tends to do better for all and even for most of the race and ethnicities that I provided data on. So that bodes well. These are some of the additional factors. I mentioned the access. You can see mental health, primary care, specialty care, where we tend to do well. And the additional RVU clinic capacity, the relative value units. We are in the bottom 10% right now at 9.85%, or about 10% overall. And you can see across our VISN, we are below the median in all cases except Hudson Valley and Northport. And so just the summary, unique patient growth, we're at minus 6.7% for the 5-year period, which is ranked 18th. For enrollment market penetration, we're at 61.3%, ranked 17th. The higher penetrated areas across the VA system, they are ranked 70% or above. Unique veteran market penetration, about 36.8%. That's actual users. That's ranked 18th. And eligible veterans not seen, 377,000 plus, or 42% of the eligible veterans have not been seen. We do have veterans not seen by gender, 37,000 women veterans that are currently not seeking care in the Albany 76 counties. And then veterans not seen by race and ethnicity, Hispanic 91,000, African American 92,583, Asian 17,600, and American Indian just above 4,000. Patient growth and outreach is now a priority of VISN 2. We do want to continue to underscore how important it is for our future. So we will be including it in 2023 performance plans and monitor it more regularly. But we are well positioned for growth, a lot of factors in our favor. And so it really is incumbent upon us to continue our efforts in this area. And again, to link the outreach to gender and race specific risk factors, because as a healthcare facility, that's really the best way to attract those veterans that are not being seen, basing it on need, diabetes, heart disease, cancer screening, mental health needs. And that is all that I have today. I will make other information available to this group, the actual numbers and other maps that I'm creating, but I'd just like to stop there and join in any discussion that you'd like to have.
Joe, thank you. That was phenomenal, as always. Someone's on. I just had a general question. Do you think there'd be any value? I'm just looking at something that Glenn Gilbert had sent me last week. He put together a slide on how we compare when you talk about our quality scores on all these questions and how we compare how our patients responded to the questions versus it's the same questions that CMS sends out to like St. Peter's and Albany and Albany Med and stuff like that. And we outscored them on everything. And actually, I'll send it to the group. I realized I didn't do that. In some cases, doubling your score in terms of, the nurses always communicate well. We were in the high 80s and some of the other hospitals are in the low 70s. Do you think there's any value in because I know we're constricted in this, advertising this sort of information because we're limited in what we can and can't do compared to, say, Albany Med or St. Peter's?
Right, and I think we have to really push the envelope there. The restrictions that we have talked about are not necessarily hard and fast restrictions, and that's why I wanted to talk about the health risk factors, because if we do it as part of meeting healthcare needs, it's not restricted, and it's still questionable as to why we can't advertise, and I'll use that term. We actually can, but there's this notion that we cannot for certain things. We certainly can advertise, as you know, to meet staffing needs. You see television and radio ads for the VA, and it really begs the question, if we have a serious mental health need in the area with suicidal ideations, why would that not rise to the same level of importance than to meet staffing needs? So I think we have to question, whether there truly is a restriction, and that's why I when I presented this to leadership several times, I stressed that point, that we are not going to be able to reach the many veterans that are in need of care unless we demonstrate, how we can provide services that they do need. So I think it's something we should continue to discuss, but I would not give up on the whole notion of advertising. I think where we can use healthcare need as the rationale, we would be fine. I know that many legal minds might weigh in on this and say otherwise, and I think it's worth pursuing. But any other thoughts on that? Because I think that's really what we're talking about. How do we get the word out to so many veterans that may not even realize that they're eligible for care? And we know that that's the case in many instances.
Well, I think your approach, what you just recommended, is kind of what I don't want to say gotten away with, because it doesn't make it sound like we're doing something we shouldn't. But when Peter, our public affairs officer, when we've done media ads, that's kind of been the vein we've always used, that we're doing health education, and we tie it into making sure we talk about enrollment or job fairs or what have you. And the reason I ask is because we do a lot of outreach. Everybody on this call does outreach as part of their job, some more than others. Well, we can go to every fair, every event we're invited to. But to reach those veterans you're talking about that don't know about us, I think one of the most efficient ways would be through marketing and advertising.
Right. Yeah, and I know we've tried letters, and when I was doing research on the most effective ways, to your point, the letters to the home, while I'm not dissuading anyone from doing that, that tends not to be the most successful way. It's still television, radio, and websites. And so I think that's something we should consider, and especially with the importance of the mental health risks in the area. It's gotten so much attention about the suicide attempts, suicidal ideations, that we would be remiss if we did not try to apportion our marketing by different risk factors: mental health, high blood pressure, diabetes, cancer risks, and especially by various race and ethnicity groups that have certain predisposed risk factors. So I think that's the right way to do it. I applaud what Albany has done in the past. I think it has paid dividends. The one thing I did underscore at the Health Operations Council, even though our numbers are going down, we should consider it to be a partial success that we've been able to offset so many of the losses by death and out-migration. It's primarily the former. Not that many are leaving the area for the South, even though there's a notion that that's the case. Most of the losses that we're experiencing are due to disproportionate death rate among elderly veterans in our 76 counties. That is among the highest nationally. But we have done an excellent job in both upstate and, to a lesser extent, downstate, in offsetting some of the population losses, and that, for that reason, I think we should feel that it has been a success, and I would urge our marketing to continue in that way. If we did not do the outreach that you just spoke of, instead of having 27 to 28,000 veterans that we're seeing in Albany, and for the VISN at 275,000, those numbers would be significantly less. So we have been successful. I would urge that we continue that.
Do folks have any questions for Joe?
Hi, this is Leah. Hi, Joe. Thank you so much. That was really very enlightening and great information. I'm hopeful we'll get this PowerPoint and can share it. And I put a message in the chat. I'm the program manager for the Post 9/11 Military to VA program. We've spoken over the years. I'm wondering, do we have ways to capture those numbers? Because we know, based on research, those folks are typically over income, but those are the same individuals that, unfortunately, we do tend to turn away, that may have experienced multiple deployments. So these are folks that maybe we need to help to get service connected. We also have in the Albany catchment area, not large military bases, which I'm sure you're aware of, but a lot of active Guard and reservists on full-time orders with the state. Wondering if we have numbers or projections, looking at how perhaps ways we can partner around things like memorandums of understanding or sharing agreements with Department of Defense facilities on how we can kind of have a feeder to bring folks in.
Right. No, those are all good points. And we did have some numbers that we were able to get from Department of Defense in the past, and that actually led to some of the letter writings that we did, where we were sending it to the homes or the address on record. We don't know the extent to which that has been successful, but that's what we have used in the past. I don't know of any other information that we were able to get by name, other than some of those Department of Defense records that I think Brian Stiller had brought to our attention. So we have used that. Again, I'm going to be sharing more of the census data that comes out that will update some of the numbers. But I certainly would be willing to discuss further ways that we can try to come up with more definitive information. But we do have very good projections based on the VA actuarial numbers, and it will be updated with the census. So we'll be able to go county by county and examine those veterans that we are seeing, those that we are not seeing. I don't know that we can get them by actual name or social security number. There are some ways to do that, but the numbers by demographics, by gender, and I'm going to try to get much more by race and ethnicity. We'll drill down to those levels. Even as I mentioned, I'm looking at it by zip code. So I'm trying to come up with actually, I got that this afternoon, the actual veterans that did seek our services both last year and through April of this year, and I have it by all of the zip codes within the 76 counties of VISN 2. So we'll I think we can certainly explore, ways to get more of that information.
Yeah, I just put something in the chat. There's a program through VA called, it's actually through the Veterans Benefits Administration, called VA Solid Start, and they are getting the names and information on veterans as they are separating, but they're not feeding it necessarily into the healthcare side of the house.
Right. Yeah, exactly. And that's where I know Brian had provided us some lists that we did create, thousands of letters that did go out to the veterans' homes of those that were not seeking care. But yeah, that solution you just mentioned sounds like another possibility.
And do you know, Joe, are there things existing in the VISN around things like memorandums of understanding or sharing agreements with local military treatment facilities around TRICARE? Like I said, kind of that, not only bringing in revenue, but looking at a potential feeder for folks that are exiting the military?
No, I haven't been at meetings where they talked about that. Again, just so for everyone to know, I don't normally do this. I did it just to help out, but most of what I work on is
Performance.
Quality of care metrics and performance scorecards. So I did this sort of just to volunteer to do that, but I have not been privy to most of the outreach meetings that they've had. This is one of the few that I've been at lately, so I do appreciate the invitation, but I do not know, in all honesty, what the VISN is doing with that in that regard.
That makes sense. Thank you.
And one of the reasons, I'll be very honest, why, if you look at the NDPP, and that's the national, the network director's performance plan, and I did word searches and presented this to Dr. McInerney and leadership team, not a single word about the term veteran growth, market penetration, even derivatives of the term are completely absent from any of the VA goals or policies. One of the things I do recommend, if you want to find out what the real intent is of the organization, just do word searches where you can identify in descending order what the most important missions or goals are, and you can find out that certain things are completely absent. And so this has not been a goal of VHA to grow, and that's one of the reasons there's this notion that there's a restriction on advertising. VA is not giving anybody a green light to overtly market very aggressively. But imagine not a single word in the network director's performance plan for multiple years on anything. Every synonym or derivative of patient growth is completely absent.
Joe, if you were here, I would hug you right now.
I was feeling the same way.
I very much appreciate that you did that and shared that with the larger group, because it's something I've been saying with our quarterly management briefings and things like that for a couple of years, ever since Marianne asked me to organize outreach for us, or not organize it, but bring us together a couple years back, because it's true. You can look at VISN 1 and compare VISN 1 and VISN 2. The glaring difference is VISN 1 has a coordinated, organized outreach effort, and you can see there. I mean, it's not, they're not growing leaps and bounds, but they're not shedding veterans at the same rate as the other Northeast VISNs.
Well, it's funny, I use that same technique looking at the network director's performance plan, as well as addendums that they have issued. And pardon the slight tangent here, but I mentioned to Dr. McInerney and others that there's not a word in that NDPP even on mortality rates, infection rates, patient safety incidents. Each year there's a different emphasis. This year it's whole health, or it's on various aspects of telehealth, all crucial areas. However, I had mentioned there's not a single word about what are traditionally mortality and morbidity metrics or veteran outcomes. And I think they were shocked when I presented it, but I used some alternative methods to get at that. And I think there were some surprised faces, and they probably would be surprised at the central office level. Perhaps even the secretary would be surprised to have the official documents of VA and all of the 140 VA directors and 18 VISN directors, and not a single word about infection rates, complications, or even mortality rates, not to mention many other things from length of stay to readmissions to all other quality veteran outcomes. So they tend to just focus on a few more new or innovative areas, some of which are very important, but they leave out the bread and butter, I think. And then one of the reasons it came up, pardon my digression here, is you've probably heard Dr. McInerney has instilled a sense of urgency because we are not doing as well in our veteran outcomes, our SAIL numbers. And I pointed out SAIL isn't even mentioned in the NDPP. So you tend to focus on what gets you rewarded, especially with the performance evaluations at the end of the year. And VA did not include those fundamental mortality and morbidity measures that have long been a part of our discussion. And so you could see why marketing and outreach, patient growth, and every derivative of the term is completely devoid in those official documents, completely absent. Pardon the tangent.
No, thank you, Joe. Just because we got a few minutes left before we end, does anybody have any other questions for Joe? I have one slide I just want to pull up. Go ahead, Gerard. Sorry, Gerard, our assistant director, Gerard.
I saw all the data, and my question is, you kept referencing veterans seen. Do you mean in that year, in like between April and May? So they could still be enrolled but not seen, so they'd be in your number of patients we haven't seen? Am I correct there?
Well, no, what happens is we go back several years, so it's usually where they haven't been seen in 3 years, but that's a very good question. So these are veterans that haven't been seen in a 3-year period.
Okay, so that's a potential for us to look at too. Veterans,
right? Exactly. But yeah, but now we would like to see the veterans at least once a year, as you know, and so even to go 3 years without being seen, that's somewhat of a concern. But most of the veterans that we consider not using VA would not be using us for a full 3 years plus.
Okay, all right, good, thank you.
I do appreciate the kind attention, and thanks for the invitation. If I could, I'll make available the actual files, and as I come up with some more drill down information for the Albany market, I will make that available to you.
Thank you, Joe.
Sure.
Can everybody see my screen? I can't see you all.
Yes, I can see it.
Thank you. Thank you, Gerard. Everybody disappeared on me.
Yes, I saw the kid in the cage, yeah.
Oh, that was so yeah, that's where I put my son when he misbehaves. So this is every quarter for as long as I've worked for the front office, we do a quarterly management briefing where we report on certain metrics to the network. They moving forward, they want to try and do a little more what they're calling forecasting. So this, you can't, on the left hand side is very small, but the management review has grown. It used to be like 8 to 10 slides. Now it's 33 as of right now. But there is one slide on marketing plan. So I'm going to take a picture of this and send it to the group. If you have any thoughts about actions that one of you have actions we're taking, I have a pretty good handle on. But if you think I'm missing something that you might have just done, you know, because it always happens, last minute you get invited. Daryl gets invited to a job fair or a farmer's market. He just does it.
Right. No, this is excellent. Actually, this is part of the discussion. You're right. It was not included in the past. And based on the discussions that I was involved with and the presentations on marketing, that's why this was added very recently.
Oh, excellent, excellent.
But yes, it's not in the NDPP. So normally anything not in there was not included. We're trying to widen that scope. And regardless of whether VA said it in writing as a definitive or a foremost goal, we want to make this very important going forward. So I think this is a healthy addition, but that's why it took place recently, since we've been discussing the marketing and outreach.
Absolutely. No, historically it was just like maybe one bullet on one slide that maybe I would sneak in if there was something we did unique. But for the group, if you can think of anything that are current barriers or future enhancements, I'm gonna copy and paste this and I'll send it to the group. But just to kind of get you thinking about it, I as always I appreciate your input, except Daryl. So I would appreciate any feedback you could give me.
And this is a perfect example of perhaps where the whole issue of advertising can be discussed, where and even that term might elicit all kinds of emotions, but this would be an excellent time to perhaps bring it up. You know, how can we reach tens of thousands of veterans that are currently not presenting for care?
Well, and I thank you, Joe, for bringing it up, because I did mention that 2 quarterly briefings ago, I used the example. I was stuck waiting to pick up my kids from school, and I was listening to the Yankees Red Sox wild card game, and during the break there was a 30-second ad on the Red Sox local station WEEI for Vision 1, and I just mentioned that, and it was a Vision ad. It was just, you know, for all the, well, I think they're the Northeast, whatever they call themselves, but and then call this number if you served in the military. And it was a great short spot, and I heard it here in New York, and any veteran listening to it on their satellite radio, wherever, if they're in Florida for the winter, everyone heard it. You know, those sorts of things, there's a real value to that.
Well, absolutely. I think that's a great example. And especially, I think if we tie it to a well-defined need based on all of the constituents that we have, I can't see how that would be frowned upon.
Yep. Yeah, I'm gonna sit down.
Since, and we have capacity too.
Hey, if you don't mind, I'm gonna chime in a little bit. I kept quiet due to Sean's resentment toward me. But recently, Peter Potter and myself were on WGY Radio in Latham, and we were on as guests for a radio program celebrating all those who gave their lives for this country during the Memorial Day holiday. And when I left the radio station, I went home, and it was on a weekend and doing errands and stuff. And I ran into a couple of the guys that I know that are veterans, and they had listened to that radio program. I also got some text messages and, the usual social media comments from some of the vets that I know in the community who had also listened to the program. Unfortunately, I didn't get an opportunity to talk about how easy it is to sign up for VA healthcare and how simplistic the process is, and easy ways that you can even do it at home. The host kind of dictated, what we were going to talk about, service connection, priority groups, that sort of thing. But I was kind of surprised that so many guys that I didn't think, still listen to radio on the airwaves, were listening to this program. And so
Yes.
that was very surprising to learn once that came out. So I just wanted to chime in, put that in there. And Mr. Cohen, one question I did have for you. A lot of data here, some of it very stunning to me to see these numbers. But I'm sure one thing I didn't see is veterans by era. World War II, Korean War, Vietnam War, the Cold War era. Those veterans
Right. No, absolutely. I have a lot of that. I should have prefaced my comments by saying this is just a subset of information. I'm very cognizant of all of the eras, and I usually do it by age and catch and eras from. We did when I was doing this, I had a lot of World War I numbers, believe it or not, and then of course World War II and Korea, Vietnam. So yeah, that information is as part of an ongoing dialogue that we need to have. But yeah, this was not meant to be all encompassing. There are other drill downs that I did not have in this rather abridged presentation. But you're right, that's very important.
Yeah, and the reason I bring that up is because a lot of, the vets that I see either didn't serve in the theater of combat or they're post-Vietnam, and they went on to establish careers, own homes, that sort of thing. And the biggest stumbling block for this vast majority of veterans is they're over the income threshold for VA enrollment. And so there's nothing we can do about that. So just wanted to add my 2 cents, that's all.
No, it's a very good point. I was also thinking when Sean was mentioning about various shows that there are questions and answers and perhaps misconceptions that we could perhaps resolve, even about how easy it is to sign up, because many may think it's a very cumbersome, labor-intensive process. So I wonder if there are ways that we could perhaps resolve some of these erroneous notions. Even there are veterans anecdotally at meetings I just attended where they thought their applying for care would take away from other ex-servicemen who could also be potentially be seen for care. So they were very civic-minded of their brothers and sisters in the military, and they didn't want to take away from their care. But that, of course, would not really be the case. But they did not know that, and they were thinking of other veterans saying, "I really wasn't injured, so I'm going to." Decline application, and they were encouraged, no, you can still be seen for primary care and cancer screening, hypertension, and so forth. And they thought they needed to sustain an injury in service.
Well, the good thing is WGY has invited us out to come out to their station again. But I think every time Mr. Potter goes out there, he'll be bringing some different staff members to talk about different aspects of VA healthcare, especially here in the capital region in our community. So that's going to be coming up, I hope.
Well, that's great. Yeah, that's. But there's so many things that many of the veterans in the area don't necessarily know, because we haven't necessarily made the information available, or they just may be unaware of it, as many do not know. I always had to tell my father, who was a Korean War Marine, that he could seek care in the VA when I first started joining, when I joined VA, and he was not told that he could seek care back in Brooklyn, where I'm from, and so he thought he was taking away from care from other veterans that were injured. So that information is still out there, unfortunately, that we haven't necessarily corrected.
Joe, you're absolutely right. I want to thank you again for joining us. I will send out, when Joe sends me the slides, I'll send them out to the group, and then I'll send that one slide that I just showed everybody, just to see if I can get your creative juices flowing. So thank you.
Well, yeah, thank you for the invitation. I really appreciate discussing it with everybody, and look forward to continued collaboration.